Hi, welcome again. So let's proceed to the cytokines and chemokines. The immune response to shock encompasses the elaboration of mediators with both pro-inflammatory and anti-inflammatory properties. Furthermore, new mediators, new relationships between mediators, and new functions of known mediators are continually being identified. As new pathways are uncovered, understanding of the immune response to injury and the potential of therapeutic intervention by manipulating the immune response following shock will expand. What seems clear at present, however, is that the innate immune response can help restore homeostasis, or if it's excessive, promote cellular and organ dysfunction. Multiple mediators have been implicated in the most immune response of shock. It is likely that some of the most important mediators have yet to be discovered, and the roles of many known mediators have not been defined. A comprehensive description of all the mediators and their complex interactions is beyond the scope of this chapter. For a general overview, a brief description of the more extensively studied mediators, as well as some known effects of the substances, see the following discussion. A more comprehensive review can be found in Chapter 2 in the Systemic Response to Injury and Metabolic Support. Tumor necrosis factor alpha, or the TNF alpha, was one of the first cytokines to be described, and it is one of the earliest cytokines released in response to injurious stimuli. Monocytes, macrophages, and T cells released this potent pro-inflammatory cytokine. TNF alpha levels peak within 90 minutes of stimulation and return frequently to baseline levels within 4 hours. Release of TNF alpha may be induced by bacteria or endotoxin and leads to development of shock and hypoperfusion, most commonly observed in septic shock. Production of TNF alpha also may be induced following other insults such as hemorrhage and ischemia. TNF alpha levels correlates with mortality in animal models of hemorrhage. In contrast, the increase in serum of TNF alpha levels reported in trauma patients is far less than that seen in septic patients. Once released, TNF alpha can produce peripheral vasodilation, activate release of other cytokines, induce procoagulant activity, and stimulate a wide array of cellular metabolic changes. During the stress response, TNF alpha contributes to the muscle protein breakdown and cachexia. Next is interleukin 1, or IL1. Has actions similar to those of TNF alpha. IL1 has a very short half-life, 6 minutes, and primarily acts in a paracrine fashion to modulate local cellular responses. Systematically, if IL1 produces a febrile response to injury, again, IL1 produces a febrile response to injury by activating prostaglandins in the posterior hypothalamus and causes anorexia by activating satiety center. This cytokine also augments the secretion of ACTH, glucocorticoids, and beta endorphins. In conjunction with TNF alpha, IL1 can stimulate the release of other cytokines such as IL2, IL4, IL6, and IL8. Granulocyte macrophage colony stimulating factor and interferon gamma. Next, IL2. IL2 produced by activated T cells in response to a variety of stimuli and activates other lymphocyte subpopulation and natural killer cells. The lack of clarity regarding the role of IL2 in the response to shock is intimately associated with that of understanding immune function after injury. Some investigators have postulated that increased IL2 secretion promotes a shock-induced tissue injury and development of shock. Others have demonstrated that depressed IL2 production is associated with and perhaps contributes to depression in the immune function after hemorrhage that may increase the susceptibility of patients who develop shock to suffer infections. It has been postulated that overly exuberant pro-inflammatory activation promotes tissue injury, organ dysfunction, and subsequent immune dysfunction or suppression that may be evident later, emphasizing the importance of temporal changes in the production of mediators. Both the initial excessive production of IL-2 and later depressed IL-2 production are probably important in the progression of shock. Next page, IL-6. IL-6 is elevated in response to hemorrhagic shock, major operative procedures, and trauma. Elevated IL-6 levels correlate with the mortality in shock states. IL-6 contributes to lung, liver, and gut injury after hemorrhagic shock. Thus, IL-6 may play a role in the development of diffuse alveolar damage and ARDS. IL-6 and IL-1 are mediators of the hepatic acute phase response to injury and enhance the expression of activity or complement. Also, see reactive protein, fibrinogen, haptoglobin, amyloid A, and alpha-1 antitrypsin and promote neutrophil activation. So we can say that those acute phase reactants such as CRP, haptoglobin, they are increased due to IL-6. Next, IL-10. It is considered that an anti-inflammatory cytokine. Again, IL-10 is considered as an anti-inflammatory cytokine that may have immunosuppressive properties. Its production is increased after shock and trauma and has been associated with depressed immune function clinically, as well as increased susceptibility to infection. IL-10 is secreted by T cells, monocytes, macrophages, and inhibits pro-inflammatory cytokine secretion, oxygen radical production by phagocytes, adhesion molecule expression, and lymphocyte activation. Administration of IL-10 depresses cytokine production and improves some aspect of immune function in experimental models of shock and sepsis. Recent studies point that importance of chemokines, a specific set of cytokines that have the ability to induce the chemotaxis of leukocytes. Chemokines bind to specific chemokine receptors and transduce chemotactic signals to leukocytes. The significance of this large family of chemoattractant cytokines in immunology is difficult to understate, as almost every facet of the immune system is influenced by chemokines, including immune system development, immune surveillance, immune priming, effector responses, and immune regulation. Okay, so that's it for our immune and inflammatory responses. Next is complement. The complement cascade can be activated by injury, shock, and severe infection and contributes to the host defense and pro-inflammatory activation. Significant complement consumption occurs after hemorrhagic shock. In trauma patients, the degree of complement activation is proportional to the magnitude of injury and may serve as a marker for severity of injury. Patients in septic shock also demonstrate activation of complement pathway with elevation of activated complement proteins C3A and C5A. Activation of the complement cascade can contribute to the development of organ dysfunction. Activated complement factors C3A, C4A, and C5A are considered potent mediators of increased vascular permeability, smooth muscle cell contraction, histamine, and arachidonic acid byproduct release and adherence of neutrophils to the vascular endothelium. Activated complement acts synergistically with endotoxin to induce the release of TNF Alpha and IL1. The development of ARDS, MODS in trauma patients correlates with the intensity of complement. Again, the development of ARDS and MODS in trauma patients correlates with the intensity of complement activation. Complement and neutrophil activation may correlate with the mortality in multiply injured patients. So that's it for this part. So see you, and we will read on neutrophils and forms of shock. Thank you.